almost all the trials comparing full complete removal of the breast tissue, that is mastectomy, compared to breast conservation, where only part of the breast containing the tumor, that is lumpectomy or breast conservation, followed by radiotherapy. All trials comparing these two procedures have revealed a higher local recurrence in lumpectomy radiotherapy group compared to full mastectomy. In fact, the first trial showing the benefit of breast conservation by Professor Umberto Veronesi in the famous Milan 1 trial started in Milan revealed 8% local recurrence in the quadrantectomy group compared to only 2% in the radical mastectomy group after 20 years of follow-up. And subsequently, all other trials have also confirmed that there is high local regional recurrence in lumpectomy radiotherapy group compared to mastectomy. So, we are offering skin and if possible skin and nipple sparing mastectomy in ladies with early breast carcinoma where skin is normal and nipple is not involved. If nipple has say ulcer or Paget's disease or nipple retraction, we can remove the nipple and still perform skin sparing mastectomy. In the radical mastectomy, the entire breast tissue along with the skin over the tumor and the nipple areola are removed, whereas in a skin sparing mastectomy, which is offered in selected cases where tumor is away from the skin envelope and away from the nipple areola, we preserve the native skin of the mammary gland, the breast, and this gives a better result in terms of appearance and quality of life. The lady looks at her own body with her own native skin of the breast as well as the nipple areola, and she feels better. So, quality of life is better in ladies who have undergone treatment for breast cancer by skin and nipple sparing mastectomy. Classically, it has been used for tumors less than 3 centimeters in size or ladies who have diffuse tumor in the form of ductal carcinoma in situ or DCIS with diffuse microcalcification shown on the mammogram. In those ladies, it has offered excellent result. And if tumor is away from the nipple, we can certainly preserve the nipple. If it is only a 2 millimeter tumor without any diffuse microcalcification, without any evidence on imaging like mammogram or MRI of diffuse nature of the disease, then perhaps it will not be an appropriate treatment. It will be overkill. However, we can certainly avoid radiotherapy if the lady does not want radiotherapy or she has some medical condition which preclude the use of radiotherapy such as scleroderma or other autoimmune diseases involving skin. There radiotherapy has severe radiation reaction, or if there has been radiotherapy given to the chest area due to prior lymphoma in childhood or early age, then again it is not suitable for second dose of radiotherapy. The third situation would be where radiotherapy cannot be given as a tumor which was initially treated by lumpectomy and radiotherapy, and has now the lady has developed a new tumor in the same breast. Conventionally, we do not offer radiotherapy again to the same breast, and therefore, breast conservation after breast conservation is not a possibility. The second recurrence in the breast is usually treated by mastectomy. So, skin sparing is a better option of mastectomy where tumor is away from the skin and away from the nipple. We are performing this procedure through a lateral crease incision, which is not very popular. Most surgeons perform skin sparing mastectomy by a periareolar incision, where an incision is made around the areola and breast tissue is removed. However, in our approach, we are performing this procedure through a lateral mammary crease incision, where we place the incision at the lateral mammary crease and then approach the breast tissue, raising a thick flap about 1 to 1.5 centimeter thick from the skin. We have performed some research in this area and found that there is a clear plane of breast tissue separated from the subcutaneous fat, and this plane is called pre-mammary facial plane. And we found that the pre-mammary fascia is located 1.8 centimeter or so in the upper outer quadrant from the skin, and in the lower inner quadrant it is about 1.2 to 1.3 centimeter away. So if we raise a flap about 1 centimeter in thickness, we should be safe in removing almost all the breast tissue.